lot more than that across the whole world. Just looking on the ELSO website recently, there were over 700 different centers registered. So it was just mind-blowing seeing all those different places registered that contribute data into the ELSO database. And thinking about ELSO, this is the extracorporeal life support organization that actually was established in 1989 and helps to develop guidelines for ECMO use, helps to develop quality assurance and education to help guide the different centers who provide extracorporeal life support for patients across the nation, and develops regulatory issues and registry support, and supports a database that implements and records information, including clinical needs, and supports research. And there's a website there listed if anybody's interested in looking at that. Okay. Let's see. So just thinking about extracorporeal membrane oxygenation, or ECMO, this is a mode of cardiopulmonary support. It's utilized to treat pulmonary failure or cardiovascular insufficiency or failure. It was actually adapted from cardiopulmonary bypass and used in which is used in the OR for cardiac surgery, and it can be utilized for infants, children, and adults, and it's the ultimate form of life support. It should be considered if the process that it is utilized for is severe, acute, and potentially reversible. So there are several questions that you have to ask yourself when you're thinking about utilizing ECMO support in a patient. What is going on with your patient? Is the disease process that I'm trying to treat, is it severe enough to need ECMO support? Is it an acute process that is potentially reversible? Because this is a treatment that does not cure anything. This disease process needs to be reversible. It does not treat underlying pathology. It provides support while the disease process resolves or reverses. And it's only appropriate if the underlying pathology is potentially reversible. It provides prolonged respiratory and cardiac support while the body recuperates, while the antibiotics work, while the lungs heal, while the heart recovers, while the body heals. And this was a concept that was very hard for me at first to try to understand and try to explain to the families of children that were first placed on ECMO when I started caring for these patients initially. Because when we first place them on ECMO and they pinken up and they start getting better and we start weaning things away, the families are like, oh, they're all better. And you have to tell them, they are a little better, but this doesn't fix things. This helps them for a little bit, but it doesn't, it buys them time. And these are very hard concepts for families to come to terms with, especially if something goes wrong, because ECMO comes with its own set of complications. Okay, so remember that ECMO is the type of life support that has some physiologic functions, and the main physiologic functions and goals are to provide oxygen delivery to meet metabolic demands and a removal of CO2, and they achieve this through an artificial lung or membrane. And the goals are to improve tissue oxygen delivery and to remove CO2 in order to allow normal aerobic metabolism while the heart and lungs rest and recover. And another caveat of the ECMO machine is that it can also perform as a renal replacement therapy by incorporating dialysis into the ECMO circuit in parallel as well. So that can also be one of the functions of the ECMO circuit, and perfusionists have also utilized the ECMO circuit as a dialysis machine. But the two main physiologic functions are oxygen delivery and CO2 removal. Here is a basic ECMO circuit. You can see here, can you see the, okay. So here's a basic ECMO circuit, and you can see that blood is removed from the patient and via venous drainage of venous circuit. It is transported from the infant through and to the patient. This is one of your basic forms of ECMO circuitry. Fluids can be exchanged here anytime that blood is taken out of a patient and transported through an artificial tubing. It has to be heparinized to keep it from clotting. So there are also issues with anticoagulation associated with this. So as caregivers of these patients, we have to watch for bleeding for these patients as well. So you can see here that coming from the venous cannula, this patient is centrally cannulated. Blood comes from the venous cannula, is transported, it passes with the pump through the membrane oxygenator, and then it goes through the oxygenator where CO2 and oxygen are exchanged back to the patient. So key determinants of oxygen delivery for this patient is in the system itself, is through the oxygen artificial membrane, and then it's also determined by the blood flow through the circuit. Patient also influences oxygen delivery minimally. The native heart function and circulation still play a role, as well as the native lungs in the body, but it can be a minimal role. So the patients can also be intubated and ventilated, so those things still play a role, but ECMO circuitry and the lung membrane can play the major role of oxygen exchange for the patient as the lungs heal. Oxygen function for the exchange of O2 in the circuit has to do with the FiO2, the membrane capacity, red cell exposure and gas exchange area, and that has to do with the duration of time that the blood spins through the oxygenator, the amount of blood that the hemoglobin that the patient has, and the blood flow through the oxygenator. Carbon dioxide removal depends on the gas flow rate and the CO2 gradient through there, your sweep flow. It's relatively independent of the blood flow. So you have to have enough venous flow and the venous flow cannula with that. So your mode of ECMO is dependent on your disease process that's going on. We want to determine what type of mode to put the patient on, whether we need a venous arterial mode or a vena-venous mode. We can break it down into cardiac. Do we need to support the heart, or respiratory? Do we need to support the lungs? There's also a rescue mode, but I'll talk about that more when I talk about ECPR. So that'll be towards the end of this lecture. So for pediatric cardiac ECMO, this comes along if we have, this is needed if we have reversible dysfunction of the heart and or lungs. It's indicated when we have high lactates, hypotension, low saturations, low urine output, so basic cardiac dysfunction or low cardiac output. That's not responding to maximal support. So that means that we've maxed out our inotropic support, ventilatory support. We've attempted to support our cardiac output as much as possible, or we have irreversible dysfunction. We have significant myocarditis and poor cardiac output, and we're thinking about bridge to transport. Are we having to resuscitate our patient? We have significant myocardial stun following cardiac surgery that's just not responding to any of our interventions, and we need to transition to more support or full support of ECMO. For pediatric respiratory ECMO, just remember that all mechanical ventilation can cause acute lung injury, whether that's pressure ventilation, volume ventilation, jet ventilation, APVR ventilation, high flow ventilation. And remember that earlier is better. You want to think about ECMO before irreversible lung injury occurs. Some selection criteria is when
Lynn, I'll just take a little break. I think this is a very important point for the nurses.
yes,
Earlier the better. And as I
early.
have evolved in my practice, practicing as an independent practitioner, I think this concept has changed. Previously, and I think even in our ICU, we beat up the lungs to the point that when the lungs are trashed, we say, okay, let's do ECMO. There's no point of doing ECMO. There is a big randomized control trial that's going on in the country from NIH in adults. They're doing 2, 5, and 7 days. So they are
Yes,
thinking even within 48 hours, if you feel there is no recovery, ECMO is good. And if
yes,
in COVID patients, they're not even doing, they're not even intubating
right.
patients. They're just doing ECMO cannulation under conscious sedation because positive pressure ventilation or mechanical ventilation is poison for lungs. You don't want to
Correct.
lungs and then heal the lungs and
Mhm.
artificially damage the sick lungs that have already damaged at the alveolar level. So I'm just interrupting because this is a very important point, and we are starting an ECMO consult service, hopefully, in which
Mhm.
anybody on the bedside can ask the physician on service, do you think this patient needs ECMO? And
Mhm.
the ECMO consult service will kick in, and it's going to be a team of physicians. That's not going to be the physicians taking care on the bedside. It's going to be a separate team, and they're going to make an independent decision. Let's before we kill the lungs, let's put the kid on ECMO. ECMO is not bad. ECMO is not scary. ECMO is a tool that is designed to heal the unhealthy lungs sooner rather than later. So I'm sorry to interrupt, but Lynn,
Oh,
that's
no.
something I wanted to stress out.
This, this is a great discussion because more and more the research is showing that if we are floundering and our conventional treatments are not working, then we need to intervene sooner rather than later. Because if we keep beating up, if we keep doing the same thing over and over again and it's not working, we need to do something different. Because we're causing more and more injury with this positive pressure. Even our protective lung strategies aren't working. So, but some of the criteria for even ECMO placement are saying that even waiting, they're saying that patients that are even chronically ventilated for more than 10 to 14 days, you've waited too long. So, and that's what some of the newer research is showing, that we're hurting the lungs too much, even ventilating them for a couple of weeks on high vent settings. So, but even with hypercarbic respiratory failure, barotrauma, high, your PF ratios, your static lung compliances, all of these selection criteria are there to help you make well-informed decisions in order to make a decision to go ahead and utilize ECMO therapy sooner rather than later. But Dr. Gupta is correct. Having this as a tool in your back pocket to say, what we're doing is not working, let's go ahead and proceed. So here are some of the diagnoses for ECMO consideration, both cardiac and respiratory: congenital defects, cardiac arrest, cardiogenic shock, refractory hypotension, myocardiopathy, myocarditis, uncontrolled metabolic acidosis, all of those things that we can see in the cardiac unit, but also the things that we see in PICU: viral pneumonia and bacterial pneumonias, aspiration pneumonia, ARDS, acute respiratory failure, near drownings, acute sepsis. But we also see, since we're having the burn units now, inhalation burns, fulminant sepsis is a bad one that can benefit from ECMO consideration as well. So some of the pediatric ECMO diagnoses are listed here as well. A lot of the cardiacs will fall in this green area. So you can see that we're not a big part of them, but we do play a big role in ECMO. Some inclusion-exclusion criteria, and these may change because over the years, equipment has gotten better, skills have improved, the equipment's gotten smaller so that we can actually utilize it on much smaller patients. Our skills are improved so that we are having tighter parameters and are able to care for these patients much better. But we still have to think about the patients that we put them on. Is the process that they're going through potentially reversible? Do they have we have to avoid those uncorrectable cardiac defects. What is our end goal? We do have to do the head scans and make sure that they don't have hemorrhages. Do they have a coagulopathy that is correctable? They have to have an absence of lethal anomalies or malignancies. And then absence of prolonged mechanical ventilation with high ventilatory settings is one of those exclusion criteria that we were just speaking of. And then again, malignancy or irreversible disease are exclusionary. Intracranial bleeds, unwitnessed arrest or cardiac arrest greater than 30 minutes. But this may be changing with the advent of ECPR. And we'll get into that just a little bit here in the next half hour of our lecture. Multi-organ failure. If you have more than one organ that's failing and you don't have an endpoint, what is the goal of ECMO? What are we doing this for? What organ are we trying to save? What is our goal? Severe brain injury. Do we have a hope of recovery? Is this going to give us a viable option? We have to have a goal. End-stage chronic organ failure, this is not an option for patients in this predicament. Overwhelming sepsis, age, parental refusal. Parents do have a right to say no. So they have to have consent to do this procedure. That comes to defining the purpose for ECMO support.
One more second, if you don't.
Yes.
So again, I think this is a very important point. The contraindications. So as the ECMO has evolved in the last 15, 20 years all over the planet, Australians and French, they were the most aggressive in using ECMO. And we have learned in North America, we have learned a lot from them. They never said no to anything. And they said it's a case by case basis. As Lynn said, a lot of these contraindications were absolute contraindications in the past. Now all of them have become relative contraindications.
Yes.
As science is evolving, ECMO is evolving. For example, malignancy. It used to be a big no-no. And now most of the centers are doing malignancy unless it's totally irreversible, that the cancer is so overwhelming that there is no hope. But if there is a hope, we still do it. Overwhelming sepsis. People completely flipped over. It was a big no-no, and now people are doing it. ECPR greater than 30. If you see most of the ECPR literature in pediatrics, they have about 30% of patients who get ECPR despite having very prolonged periods of cardiac arrest, chest compressions, and the outcomes are not that bad.
Yeah,
Stroke,
and I'll talk about that soon. Yeah.
yeah, and stroke, the same thing. Ischemic stroke, we have put kids on ECMO whose brain, half the brain is dead, but we still have done it and the kids have come out great. I'm not saying just do everything and anything, but a lot of these contraindications have changed from being absolute to relative. And Lynn, I don't know your slide deck, so I'm so sorry to kick in. I'm just saying
No, no.
these are very important points for the bedside nurses not to think sometimes we do supraheroic efforts on the bedside and people are thinking, what are we doing? But outcomes are the other way around, that they're great outcomes. So that being said, I just want to say like a lot of these things are relative and we go on a case by case basis too.
Which is why we have to define the purpose for the ECMO support. You know, is there failure of pulmonary cardiovascular or both, which defines do we need VA or VV? Is the process leading to the failure reversible? Do we have a hope of turning it around? Is it reversible within a reasonable amount of time? You know, how long do we expect them to be on ECMO? If it's not reversible with recovery, can we reasonably expect to get an organ transplant, or is transplant an option? Those are questions we need to ask before we step ahead and proceed. So we need to realistically define, why are we doing what we're doing? How do we proceed? What equipment do we need to use? And what is our end goal? And is this something that is realistic for this family? Is this a bridge to organ recovery? Can we provide the time needed to recovery of function to facilitate the therapy, surgery, or medical therapy that this patient needs to recover? Or is this a bridge to receive an organ transplant? Or we just need to provide them support long enough to get a suitable donor organ? Or are we just providing time to make a decision? So we need to provide them support to make a decision for that next step. Are we needing another form of ECLS device? Is that a VAD support? Is that a CO2 removal device, or is that to palliative care? Where are we going with this? And is this an appropriate decision for this patient? Those are the questions that we need to sit down and ask before we proceed with the therapy that we're contemplating. And then that's when we need to make the decision what kind of therapy that we need to proceed with. So the two types of ECMO support that we'll most likely see in our unit are going to be our VA, venous to arterial support, or VV ECMO. So VA is a cardiac or cardiopulmonary, or for cardiac or cardiopulmonary failure, and that's to support poor cardiac and/or lung function, and it supports both the heart and the lungs. It usually requires 2 cannula, one in the jugular vein and one in the carotid artery, or if you have an open sternum, it's directly into the heart itself. For VV, venous, that's for a patient who's in respiratory failure. They need to have good cardiac function, and it supports a patient with poor lung function, mainly supports the lungs, and requires usually 1 cannula into the jugular vein. There's, for VA ECMO, here's some cannula sites, some pictures of how some cannula sites look. If they're cannulated through the neck here, you can see how that looks. Femoral vein here, open sternum. Usually they're directly through the open sternum into the chest. For VA ECMO, usually benefits, they decrease the cardiac work. It reduces cardiac oxygen consumption, provides adequate systemic organ perfusion with oxygenated blood, prevents overdistension of the ventricles, and helps in cardiac recovery, helps to maintain adequate tissue oxygenation, and allows recovery from short-term cardiopulmonary failure. The goals of VA ECMO are to temporarily improve circulation, oxygen saturation, CO2 removal. It helps to rest the injured heart and lungs and avoids or minimizing injurious therapy, helps to maintain stability in organ function, and helps in recovery of organ function and is a bridge to definitive treatment while minimizing complications from ECLS therapy. There's some advantages and disadvantages of it, and we talked a little bit about the advantages. I like that it has almost instant hemodynamic support and stabilization, usually no recirculation through oxygenation at high flow, and the right heart is offloaded and rested and allows for lung rest for VA ECMO. But usually has non-pulsatile blood flow, and then once we're decannulated, you may have to have some vessel ligation if we're cannulated through the neck or the groin for disadvantages. And you can have some reduced pulmonary blood flow as well. For VV ECMO, you can be either cannulated through the neck or the neck and groin. Here's a neck cannulation. Now for VV ECMO, for older people for VV ECMO, it's kind of nice. You can have a awake VV ECMO, and for a lot of our pulmonary patients who are awaiting lung transplants, they are up and ambulating and walking and doing a lot of rehab and able to get up and get out of the bed and move about with their ECMO support if they're cannulated in the jugular. Some can be cannulated in the femoral. You just have to be careful because you have to make sure that the distal extremity has perfusion as well, because there can be some perfusion issues with that cannulation site. VV ECMO provides oxygenation, blood is drained in the venous system, returned to the venous system. It only provides respiratory support. It can be done by peripheral cannulation, usually can use both femoral veins at times. Vent settings are adjusted to allow for lung rest, and can avoid oxygen-induced lung injury. Temporarily improves oxygen saturation and CO2 removal and helps to rest injured lungs. And it also helps in recovery of organ function and is a bridge to definitive treatment while minimizing complications. there are some advantages and disadvantages as well. The advantages are that you have oxygenated lung blood. There's pulsatile blood pressure because the heart usually maintains its cardiac output. You have oxygenated blood delivered to the root of the aorta, so you have myocardial oxygenation. Not usually affected by PDA if you have an infant, yay. And then disadvantages is usually no cardiac support or very little. You can have a reverse gas exchange in the lung if FiO2 is low, though. There's slower stabilization and for some of the disadvantages there. There's differences between VA and VEV ECMO, and I listed those out there. And we kind of went over those just a little bit when I separated those out. But just remember that the main difference is that VA ECMO provides cardiac support to the systemic circulation, and VV ECMO does not provide that cardiac support to assist systemic circulation. So, and then you have to remember that if you have right ventricular failure, that you need to have the VA ECMO support. Okay. I'll let you look through those. Oh, thank you. So some of the risks of ECMO are listed out here. Remember that ECMO itself is not a benign procedure, that there are several risks associated with removing the blood from the body and passing it through an artificial tubing. You can have cannula dislodgement and bleeding, exsanguination. There can be perfusion issues, embolism, air embolism. You can have thrombi occur in various areas, not just in the tubing itself, but also in the body, microemboli in the body, particles that can form clots in any part of the body. There can be mechanical complications such as oxygenator failure, pump failure, or circuit failure itself. Harlequin syndrome, where the part of the blood becomes oxygenated in part of the body and deoxygenated in another part of the body. It's really unique when that happens because you can see the shunting of the blood manifest itself in different coloration, and half of the body becomes red and the other half is a different color. So, heparinization of the body can result in bleeding, so you can have abnormal bleeding in the head, so you can, especially in our younger children and neonates especially, you can have interventricular hemorrhaging. Older children as well, and adults can also have head bleeds. You can have GI bleeds, especially in the splenic area. And then post-operative patients can also have bleeding, especially at suture lines. And then multi-organ system failure can occur. You have kidney, liver dysfunction, GI issues. There can be also lung hemorrhaging, can be a big issue. Skin ulcerations, infection can be a big risk. You don't usually routinely use prophylactic antibiotics in ECMO patients, but remember that infection and systemic inflammatory syndrome can be a big risk for ECMO patients. Transfusion reactions, since we do use a lot of blood products in these patients, can manifest, and pain and sedation can also be problematic since the ECMO circuit itself can absorb some of the pain medications, and sedation for these patients can be an issue. The benefits of ECMO patients with a predicted 80 to 90% mortality rate now have a chance of survival. So ECMO provides time for healing and for further treatment that may resolve the primary problem that has put them at risk. So the key to the success for ECMO may be the time of initiation. So like Dr. Gupta said earlier, timeliness, getting them on ECMO is the biggest benefit of utilization. For patient management, we really want to look at their systems. We want to feed them, give them good nutrition, supplement their fluids, make sure that they have appropriate sedation and analgesia. When I first started taking care of these patients, everybody was sedated and paralyzed, but now we're allowing them to wake up and look around. We're also extubating them and allowing them to walk about and doing rehab with them. Antibiotics, we're using fewer and fewer antibiotics on ECMO, but they're still at risk for infection, especially some of our surgical patients. Invasive procedures, bronchs are becoming more and more, we're doing a lot more bronchs on some of these patients, especially if we're looking at our VV ECMO patients. If we're having ARDS patients and flu patients, looking at how we're treating them, getting very specific at how we're treating them, and then weaning them as quickly as possible in order to decannulate them and getting them into rehab as quickly as possible as well. So from a cardiovascular management, if they're hypotensive, we want to get them volume. If they're volume depleted, they have increased blood drainage into the ECMO pump in order to improve their venous return. We need to increase the preload into our LV and RV, so we make sure that they have enough volume going in. Calcium is important in improving myocardial and contractility, so that's an important electrolyte to monitor. Vasopressors are also important. They increase systemic vascular resistance, increase the LV and RV afterload. Milrinone can also be beneficial, but we also have to watch it in cases of renal failure. Hypertension can be common in VV ECMO patients, so we need to think about ACE inhibitors in those patients as well. For pulmonary support, we aim to control pH and CO2 with the ECMO circuit as opposed to with the ventilator. We need to look at the sweep gas flow rate to increase CO2 removal. If we're looking at lung aeration, we can adjust PEEP. And then for infants, we can look at surfactants. But we want to minimize ongoing lung injury. So we can adjust peak inspiratory pressures for recruitment. And they suggest looking at high flow ventilations and adjusting peak inspiratory pressures and maintaining low peak inspiratory pressures and low respiratory rates to utilize rest ventilatory settings for these patients. And then provide adequate myocardial oxygenations with FiO2s around 40%. We want to also think about preventing ventilator-associated pneumonias with respiratory treatment, appropriate suctioning, lung recruitment, prone positionings. is also another thing to think about. I always cringe when I think about putting a patient prone on ECMO, simply because I'm a cardiac nurse and a lot of my patients had open sternals. But if you think about VV ECMO and cannulation through the neck, prone positioning is something that is maybe necessary for lung recruitment. So, and then doing all the things that are necessary to keep those lungs open, lung conditioning and IPV and CPT and all the respiratory treatments needed to mobilize secretions and keep them suctioned in and out. So for fluid management, we need to maintain good intravascular volume, 90 to 100 cc's killed per day. There can be capillary leak syndrome and third spacing of fluid depending on what's going on with your patient. There can be cytokines, complement, leukocytes, depending on if they're septic, if they're a burn patient, if they're, have just went through a big surgery of some type, if they have significant vasodilation or increased vascular permeability due to these things that have been going on with them. So they can have oliguria, often associated and worsened on ECMO support, and that can be due to the non-pulsatility of flow, especially if they're on VA ECMO. Some patients may be recalcitrant to Lasix and may need stronger diuretics. They may need a thiazide as opposed to a loop diuretic. So we may need to get nephrology consulted earlier rather than later. CVVH may be a helpful adjunct, a simple inline circuit. And then remember that CVVH doesn't worsen outcomes according to the research. So we may need to think about fluid management earlier rather than later and start pulling that fluid off quicker for these kids. And nutrition, enteral nutrition. If the gut works, let's use it. Enteral is the preferred method. Is decreased cost, it has similar complications. If we can decrease catabolism, we have decreased infection rates. If we can give it NG or TPT and utilize aggressive bowel regimens, we can have better outcomes. If we have to use parenteral nutrition, we need to limit our carbohydrates and fats, watch our lipid infusions though, because that can have some technical problems related to the ECMO circuit. We need to give lipids over on the patient side of things because of the layer out of the emulsions and the fat deposits. Right now, there are no direct studies suggesting an ideal mix of parenteral versus enteral nutrition for pediatric ECMO patients. So it's a guessing game in a lot of cases. But increasing caloric intake, we've got to be careful because, if we have increasing amino acid oxygenation, can lead to increased protein breakdown, and they trend towards longer ECMO runs. Some of the research is showing. There's more research saying that GI, NG feeds or TPT feeds and are better for the patients long term as opposed to TPN. But research is few and far between for nutrition in these complex patients. From a hematologic standpoint, we want to maintain our H&H 13 and 40 hemolysis. We want to monitor with plasma-free hemoglobin. Platelet consumption is very common. Recommendations are to keep platelets greater than 100,000. I've seen them, some places want to keep them greater than 80,000. giving a kid platelets every day, it can be worrisome. ACTs, run them 180 to 200. If you have significant bleeding, you may want to keep them a little tighter, 160 to 180. Amicar is a medication that inhibits fibrinolysis. Have trouble wrapping my tongue around that one, but can enhance hemostasis in high-risk cases and post-op patients. Aprotin can be given for active bleeding, but most places generally avoid it due to clot risk, and avoid Novocevin on ECMO due to clot risk as well. I've only seen Novocevin given twice on ECMO patients, and it's kind of scary. For neurologic, there's increased surface area and surface interaction and altered renal blood flow, especially if you're utilizing CVVHD on ECMO patients. Any kind of sedation medications can be difficult to regulate on these patients. Morphine is generally used due to oxygenator uptake of fentanyl, and tolerance can develop very quickly. Ativan and Versed are medications that are generally used, but less so. Neuromuscular blockades are generally required in pediatric and adult patients but we're kind of moving away from that and allowing our patients, if they can be calm. We're utilizing serial ultrasounds and video EEGs and hourly neurochecks in order to monitor for intraventricular hemorrhages in order to keep an eye on their neurological status. For infectious disease, routine antibiotic coverage is not practiced, and strict asepsis during ECMO run is needed. We really need to have a low index of suspicion for any kind of superinfection, and it may be difficult to assess for infection, because remember, we maintain their temperature on ECMO. We warm them and cool them according to the water bath that the blood goes through to be heated up to be put back into the patient, so they don't spike temps. So we have to really be cognizant of, is this patient febrile, or is this patient acting oddly? Do I need to think about, are they having a fever? Some centers send routine blood cultures every other day, depending on what their protocol is for monitoring for infection. So getting into ECPR, remember that death is described as cardiac respiratory arrest, but ECMO support creates an artificial circulation to transport oxygen and blood to the whole body and maintain biological function, and the biological process of dying is interrupted. So we may have to think about a different definition of death. So talking about ECPR, which is extracorporeal cardiopulmonary resuscitation, ECPR was first reported in 1992, and it was used to aid in-hospital cardiac arrest after cardiac surgery. And this led to a remarkable improvement in survival as compared to conventional CPR. So ECPR is a method of cardiopulmonary resuscitation that uses ECMO as an adjunct to conventional CPR. Cardiac arrest comprises about 25% of all indications for ECMO in pediatric patients. And refractory cardiac arrest is defined as a lack of spontaneous circulation occurring within a period of at least 30 minutes of CPR in the absence of pre-existing hypothermia. Remember that 30 minutes of CPR has a return to spontaneous circulation rate of about 7%. and 60 minutes of CPR has a return of spontaneous circulation close to 0%. So studies have shown that the overall survival with ECPR is close to 40%. So if we can utilize ECPR, we can actually improve our outcomes, our survival rates of cardiac arrest. Here's one of the studies that was published in 2016 that shows, I don't know if y'all can see this cursor here, but through utilizing ECPR in patients, survival to discharge improved from 27% to 40% here, with favorable neurological outcomes in 27% as opposed to 18% of those patients. Why ECPR? And this evolved due to the recognition of poor rate of recovery from cardiac arrest following utilization of just external chest compression. And it involves the rapid institution of ECLS during cardiac arrest via percutaneous cannulation of femoral vessels through a reopened sternotomy. The goal is cannulation within 30 minutes of rest, and it's limited to witness inpatient arrest. So arrests that happen in the ICU, in the cath lab, or on the floor. Many institutions who utilize ECPR keep one or more pre-primed circuits on permanent standby to facilitate ECPR, and then these circuits can usually be kept sterile for up to 30 days or more. There are actually a couple of studies out there that I read in the last few days that are, I think it's in France, where they have ECPRs deployed on ambulances. They're actually taking them to the scenes of cardiac arrest in the field. So they're doing ECPR wherever a person is receiving CPR. So it can be at the baseball field, it can be at the casino, it can be in the subway. So they're doing ECPR in the field. So I don't know how that's working out, but it just seems strange to me. But the one that I was actually able to print out and read just talked about the vehicle, and it was like a street racing car because they had to get there within a certain amount of time. So it was a street racing car. It was just odd. So ECPR is one of the most rapidly growing applications of extracorporeal life support, and it's been used more frequently in pediatrics than in neonates or adults until recently. But you have to consider resources, coordination, and organization in order to perform it effectively. And it's very challenging. In most centers, survival is less than 50% irrespective of age that this is used on. And in most experienced centers, half of the patients survive, with 75% of them having mild or no neurological impairment, which I think is pretty decent outcome. So although there are some clinical and pharmacological guidelines for the practice of cardiopulmonary resuscitation in children, that's your PALS, the practice of ECPR resuscitation in pediatric cardiac patients, there are no universally accessible standards. There are no guidelines out there for it. There's nothing about the team makeup. There are no training manuals. There are no logistics for it. There's nothing out there. There are no guidelines. There are no standards of care for ECPR. What are the obstacles to progress? There's no patient selection. There's no program structure. There's no cannulation choreography or training. There's no activation protocol. There's no CPR duration max. There are no recommendations. There's no ideal location, ICO versus OR versus arrest location. How? Central versus peripheral. you know, do we follow the PALS algorithm? There's actually been some research that says, is one dose of epi or 10 versus doses of epi okay? In fact, they're saying, you know, once you get past 3 doses of epi, that's way too much. So, and then it's resource intensive as well. How much are we going to, you know, how much should we devote to this in order to make it a viable process? Vascular accumulation is one of the most challenging aspects of ECPR, and it can be the greatest constraint to providing it. The traditional approach has been open surgical approach with vessel ligation. Percutaneous approaches are replacing surgical approaches in some situations, especially when patients are 15 kilograms or more. But a lot of our patients, especially here in the PICU, are less than 15 kilos. So if you think about a lot of our pediatric cardiac patients, you know, half of the ones we have right now are 6 kilos or less. So we need if we're going to do this, we need to have an adequate response. There needs to be a robust system. We have to have good volumes. We have to have all staff trained in their emergency responses with simulation training. There needs to be frequent rehearsal of key responses, priming, clamping, you know, who does what. There has to be logistics, ECMO safety, setup, clamps, spare circuits, prime, checklist, maintenance of training, reaccreditation, who's going to accredit it, what all goes into it. And utilization, there has to be timely recognition, fast notification, alert systems, ready perfusion teams, care coordination, and high quality CPR. And everything I read, that was one of the main focuses of each article, is that if you don't have the high quality CPR, ECPR is useless. You have to have that first and foremost. This was one of the best things that I found, is that you've got to have rapid recognition and activate the EMS and go ahead and talk about, am I going to start ECPR, period. So start that right away. And then prompt CPR. Go ahead and get it done. Go ahead and talk about it. And the ECMO. You know, whoever's doing the CPR, whoever's behind the scene, go ahead and talk about, am I going to do ECMO? Within the first 2 minutes of starting CPR, you should already be saying, is this an ECPR patient? So, and then once you've decided all that, I just thought this was a really good thing to talk about. Pre-arrest, cardiac arrest, CPR, push fast and hard all the way through it, and then post-arrest stabilization. What do I need to do post-arrest? Indication for CPR, the indications, the contraindications should be the same for ECMO and ECPR. The only patient who should not receive ECPR or ECMO should be the patient with a DNR order. And then ECPR may be indicated for prolonged CPR if good perfusion and metabolic support is documented. So that goes back to that adequate CPR, push hard and fast, and have good CPR. And then patients who have an easily reversible event have had excellent CPR are eligible for ECPR. Post-resuscitation care, you want to have controlled reoxygenation, CO2 normalization, cardiopulmonary support with the removal of pharmacological support if you have the epi-drip started. If you want to talk about normothermia or hypothermia, if this is a patient who will benefit from hypothermia, we can start that. And overall supportive care, and that goes back to all of those patient management things that we talked about for the ECMO patient, from the fluid management to the nutrition management to the neuro management and infectious management, all of that, respiratory, all of that needs to be basically the same. But coming back here, after cardiac arrest, will they benefit from hypothermia or not? Initiation of flow, we want to make sure that since this ECPR requires very rapid cannulation, and we want to make sure that all the connections are appropriate, and we need to have a timeout done, and then CNS protection. And then if they do have LA hypertension, we need to make sure that LA decompression occurs in a timely manner before they developed pulmonary edema. Diagnostic procedures, if a patient does have a cardiac arrest and requires ECPR, this patient may need a cardiac echo or catheterization or other imaging and laboratory testing to determine why they had a cardiac arrest, unless we can put a finger on it right away. For children within hospital CPR greater than equal to 10 minutes, ECPR is associated with improved survival to hospital discharge and survival with favorable neurological outcomes compared with conventional CPR. All right. So that's something that we want to undertake. I think it would be of benefit to our patient population. Any questions about ECMO or ECPR?
Yes, I do, Laura. Hello.
Hello.
Right.
So this may be a silly question, but since they kind of mentioned in the beginning that VA ECMO is for heart and lungs and VV is for lung support, how is the decision made to go to VA or VV if you need pulmonary support?
So you have to look at the reason that you're needing ECMO support. So if it's truly just a lung-only issue, then it should be VV support. So if you have good cardiac output, then you should not need VA support. So if you've got a patient who has RSV bronchiolitis that has good cardiac output, then VV support should be adequate for them. Now, if they're on VV support and their heart function deteriorates, they can be transitioned over to VA support at some point. And I've seen that happen a couple of times.
But that also depends on how they're cannulated, right? To transfer from VV to VA, or would you have to go?
So Lynn,
they can be transferred. I mean, because the VV is jugular only.
So Lynn and Laura, I think that's
depends on the surgeon too, what he's willing to do. But you would have to change out the cannula.
Lynn and Laura, I think that's a great question. A lot of logistics play in the role in picking the VV versus VA. There's no clear demarcation when you do VV, when you do VA. A lot is clinical and a lot is personal preference from the physicians, I'll say mostly surgeons and intensive. We have learned by experience, technically, theoretically, you can have a RSV bronchiolitis neonate and you can get by with VV because it's a single lung disease. Now we know from our experience, what's the conversion rate of VV to VA in neonates? 100%. So now we have learned with experience, the smaller the patient is, the higher is the risk of conversion from VV to VA, even if it's a single organ defect. Reason being, when you attach an ECMO to a patient, you have two patients next to each other, ECMO and the patient. So that means the native cardiac output that's coming from patient has to support the ECMO circuit also. So you have to be lot is, I'll say, practice driven and some is patient driven. Vice versa, I have seen a lot of single ventricles, not lots, some single ventricles with shunt physiology having a single organ disease, means lung disease, they're getting VV ECMO. So it's interchangeable, the demarcation is very unclear. It's based on physician preferences and our experience. But in the broader sense, what Lynn said is correct, that single organ, lungs only, we try to do VV. Multiple organs, when you need extra cardiac output, you want to do VA. Does that answer the question?
Yes, that does. Thank you very much.
Okay.
It's a good question. If there are any more questions, feel free to ask. Otherwise, I'm going to open up those 5 questions about ECMO and ECPR, and then we'll do a quick evaluation after that. Is everyone okay with that?
I think this was a great talk. Len did a great job. This was a wonderful talk, and we are going to repeat it in maybe in like 6 or 8 weeks.
That sounds perfect.
Thank you guys very much.
Okay, so I'm going to open up the poll now. Thank you, Lynn. And then y'all can see on in your screen, something should have popped up for questions. So. Another 30 seconds, and then we'll go over the questions. Okay, you can unmute your phone if you like to. And question number 1 is, let's see. Which of the following is not a condition usually treated by ECMO? %75% said B. Bueller?
You can put the questions on so we can see them, like the answers.
Can you share your screen with them?
Oh, yeah, let me see. Let me see. Oh, where'd it Why it disappeared? I don't know why it disappeared when I shared my screen. So Heather, you can't see the questions, the poll?
They were on a Word document with the correct answers, but you closed it out.
Once you finished the poll, the questions went away. You can't see them anymore.
Oh, they did. Okay. I'll read it out
I
loud.
can still see them. I think you have to just alter your chat window.
Maybe minimize the chat or the participants.
Click on polling. The down arrow on polling opens the polling text box.
Okay, so which of the following is not a condition usually treated by ECMO? The answer is B, end-stage malignancy. Looks like everyone got that one. Go down. Which of the following are the major advantages of ECMO support? 75% of the people saying add oxygen or CO2 and allows the lung to rest. That is correct. Good job. Number 3, criteria for abrupt termination of ECMO support may include all of the following. Except. And the answer is A, correctable cardiac dysrhythmia.
Yeah.
Okay.
You wouldn't take them off of that.
And then number 4, venous drainage to the ECMO circuit is limited by which of the following? Looks like we were kind of mixed on this question, but the answer is C, size of the venous cannula.
And that can be a little confusing, but the size of the patient shouldn't limit your.
Yeah. Size of the patient does seem like it, would play a part, but it's a cannula size.
Okay.
Number 5, the goal of ECPR is, with the majority of everyone saying A, within cannulation within 30 minutes of CPR initiation. All right, perfect, guys. And then the last thing, did we have any questions on those? Yep. Okay. The last thing I'll ask you is to take 30 seconds and just do this quick course evaluation. You'll see it pop up in your polling now. And then we'll be done. Thank everyone for logging in and attending. I hope that this was beneficial for you. Thanks, Lynn, for doing this one and being our inaugural WebEx. And look forward to having you all and more as we go on and develop more. So please tune in next week on Wednesday when Dr. Collars does hers. And we'll kind of hopefully just keep on growing. Thanks, Lynn. And if you guys have suggestions or comments how to make it better, we'll definitely, I'll hear what you guys have to say, and we can go with that. So thanks for participating today. And I think I have everybody that signed in the morning. So if you joined late or a little bit later, you might just want to shoot me a message in the chat to let me know. But I think I have everyone. So, and with that, you guys are all free to go. Thank you so much. Dr. Gupta, if you don't have anything else, we are good to go.
Hey, Travis.
Yes.
Do you want us to send our name, email, and 3-4 in this chat?
I have most of you guys. If I already have you, if I sent you, then you're good. We have people that joined us from NICU and places, so those are particularly the people that I need. But if you have my cell phone number, you can, it's fine. You can text me or whatever. But I kind of know all of my PICU people.
Okay, got it.
Okay, bye.
Bye, guys. Thank you.
Bye. Thank you.
Bye, and stay safe.
Bye.
Always, always.
Let the hail hit you this afternoon.